This works. Works for us. I think I hear your screen. I think I can't. See that. Okay. So maybe just do sound check in between or something like that. But maybe, can we get my laptop set up? Just 2 seconds and then.
If you want to just kind of tuck your stuff over to the side or something like that, or backstage, that's fine. I can use my own. So it's worth noting there is a session in between now and when you're going. So we can, I mean, probably don't want to plug this. 1 second. You good?
Oh, Matt, are you able to make an announcement in the hall to come in?
Ladies and gentlemen, if you're still wandering around in the lobby, please start making your way into the amphitheater and back to your seats, as our program is set to begin in just a moment.
Okay, as people are coming in, why don't we go ahead and get started with the introductions? And this is really, again, our upcoming last 2 sessions are really just as exciting as the morning and actually all day yesterday too. So it's an honor to, again, to welcome you to today's session on thinking about AI, machine learning for integrative health, and thinking about technology and collaboration. And so to set the context here, you know, we've talked about the ever-changing landscape of healthcare. One thing is clear, that integrating technology into integrative care models represents both a challenge and an unprecedented opportunity. And our goal today is to explore how these advancements can be leveraged to empower patients, enhance accessibility, and foster collaboration. So we have sort of 3 key objectives for this session to think about. One is to explore the accessibility of integrative health technology, integrative health through technology. How do we harness telemedicine and other innovations to bridge gaps in access, especially for underserved populations, as an example? Identify future innovations in integrative health. What breakthroughs like AI-driven personalized care, wearable tech, virtual reality transform how we approach integrative healthcare? And the other thing is to promote collaborative best practices, really fostering interdisciplinary partnerships to ensure that these innovations are patient-centric, as we've talked about, equitable and scalable. So with that, I'm going to just introduce our speakers, and we have really 3 amazing individuals. First will be Dr. Rupal Patel. Dr. Patel is a professor with interdisciplinary appointments in the Booth College of Health Science and the Corey College of Computer Science at Northeastern University, and her research interests lie at the intersection of speech neuroscience and assistive technologies. And she has an extensive bio. Actually, all three of them do. So it's all on the Whova app, but I would encourage you to read it, but you'll see why in a moment when you hear their remarks. Dr. Jagmeet Singh is a professor of medicine at Harvard Medical School. He served as the clinical director of the cardiology division and is the Roman DeSanctis Endowed Chair in Cardiology from 2015 to 2020. And he is also the founding director of the Resynchronization Advanced Cardiac Therapeutics Program at MGH. And then this will be followed by Dr. Paramesh Gopi. He's a seasoned entrepreneur and a visionary business leader with extensive public and private company experience. He's the founder and CEO of SoundHealth, health technology startup. Some of you may have seen their booth outside, focused on personalized, intelligent wearables to improve breathing and sleep. So with that, I'm going to first turn over to Dr. Patel.
Right. Good afternoon, everyone. Thank you, Darshan. Thank you, Peter, for the invitation to be here. I've been enjoying all the talks in the last couple of days and really finding it very interesting to see how all these different worlds sort of collect together. So I'm going to talk about voice as a signal. And what I'm really interested in is how speech and voice actually are incredible biomarkers for health. And sometimes they predate or precede the kinds of signals that we see in terms of actual clinical presentation of these disorders. So I study speech and voice, and what we do is we often look at signals like the spectrogram or acoustic wave to detect these changes, these subtle changes in speech and voice. And so in voice, so we make a distinction in our field in terms of what speech, voice, and language are. Sometimes we sort of clump them together, but in speech and language and hearing associations or speech and language research, we signify voice as really much more that phonatory component, where it's about pitch and loudness and signal duration and voice quality, whereas speech is more the motor act of creating words and the execution of these motor signals. So there we look at things like the articulatory precision, whether it's the right word or not in terms of language and so on and so forth. So we're going to talk about both of these together. And so there are a number of conditions that we already know of where speech and voice are biomarkers. So in terms of voice biomarkers, respiratory conditions such as COPD and asthma have poor breath support. They have short phrases as well as strained phonation when people present with these. But what can we do in terms of signaling or finding these signals actually early or on in their disease? In terms of cardiovascular conditions, we'll hear from Dr. Singh a little bit later. There are changes in tone as well as the intensity of the sound as well, and that much more fatigue. So people with respiratory conditions and cardiovascular conditions will take more breaths in between sentences because they're sort of catching their breath, because producing speech on top of just breathing is an extra kind of task. And then in Parkinson's disease, reduced pitch, mono loudness, mono pitch, the inability to really fluctuate pitch easily, those are the kinds of things that we find in Parkinson's disease. And then in depression, we have slow rate, low pitch, decreased energy of speech as well. So a number of different kinds of, might be my timer. Okay, so in terms of voice biomarkers, we know that there are conditions such as dementia, brain injury, schizophrenic, and bipolar disorders that also show different kinds of signs and developmental disorders where speech is a biomarker. I'm going to focus on voice for today's talk. And so let's go on to how different kinds of technologies that we envision, that we have now today, allow us to actually pick up these subtle signals. So signal processing has been around for years, right? So signal processing was the initial kinds of techniques that we used to look at speech and voice signals. And then we started getting things like NLP and machine learning and so on and so forth. So a lot of these technologies and tools have allowed us to not only pick up voice, but then think about how voice is correlated with these other disorders. But today we have even more kinds of technological tools such as genomics, as well as precision medicine and generative AI that allow us not only to just pick it up when we want to in terms of when asking a person to do a particular task, but much more in daily conversation as well. So what is the market size? We saw this morning's talks and some of the talks yesterday really talking about what is the, how can we bring the technology and the research from lab to the actual world? So the voice biomarker market is relatively large today. It's about $2.6 billion, but it's growing at a huge CAGR of 15.1% per year. And so we're looking at a really big market developing. And that's also because now we have the capability of capturing voice, not in someone's lab, but actually on your phone, right? And in the ambient environment as well. So huge in terms of where we're going with this technology. So there's a number of small companies, I would call them startups or spinouts, that are doing work in the speech and voice biomarker industry. But then you also have a group of the big companies, the big tech companies that have also gotten into this. They're into it because their technologies allow us to capture some of the data ambiently. And then on top of that, you've got pharmaceuticals companies as well as electronics companies also getting into this market. So you have a confluence of the market growing, the technology being small enough that we can collect this data every day, everywhere, and then people thinking about, well, what are the implications for health and wellness? Okay, but here's the problem. We've been looking at speech and voice from sort of one side. So most of the studies today are based on lab-based data, cross-sectional data, and they're usually about assessment. How can we detect the disorder early on? And they're condition focused. By that, I mean, it's focused on what does someone with Parkinson's disease sound like? What does someone with depression sound like? And so on and so forth. So very siloed kinds of understanding. And yet we could do a lot more in terms of looking at the system, thus, integrative medicine here, talking about treatment, not just assessment, but how do we follow this individual and what their voice is doing in terms of as they're progressing through a treatment, longitudinal collection of data, and then collecting this data in real life every day, because what you do in the lab, read speech is different than spontaneous speech, lab speech is different than real life speech. Okay, so where do we go from here? So I have a few sort of suggestions of where we can take all the knowledge and discovery that's happening in all these different areas, and kind of 4 different kinds of themes of where we can go from here. One is we need more normative data. So in a previous life / the last 10 years of my life, I've been focused on essentially using building a new personalized voice treatment for individuals who have to use a device to talk. And so we created personalized voices, personalized synthetic voices, and there, in order to create a unique voice for each individual who has to use a speaking device, what we had to do was collect the voice of everyday people. So everyday people donated their voice to our system, and that was what allowed us to create these unique synthetic voices for each individual by combining their voices together. But the thing I want to focus on here is, how do we get 100,000 people to donate several hours of their speech? And we called this the Human Voice Bank Initiative, and it worked. Oftentimes people think that, just trying to get people in the lab, it's going to be so hard. People are not going to want to actually record that much speech. But when there's a cause or a reason behind it, we were able to get many people over, the last 7 years or so. So now can we collect something like that longitudinally? Can we actually get data from people, not just for specific points in time, but over time? And can we share those resources between researchers and industry and so on and so forth? I think if we can do that, we can broaden the focus of what we can actually address. And here, so far, as I said earlier, a lot of the work has been done on individual disordered populations. But let's look at even conditions like menopause, which affect 50% of the population or 51% of the population. It's a huge market, about $1 billion market today, and growing again exponentially, where voice changes are common. So voice changes such as reduced pitch, increased hoarseness, reduced the ability to actually get louder in your voice, a raspier voice, persistent cough. All of these are signals of menopause. So a woman doesn't need to know that she knows she's in menopause, right? But these early signs of menopause are usually ignored. And those early signs of menopause might actually mask the kinds of conditions that are due to conditions that we could treat, such as Parkinson's disease or other neurological diseases, or even heart failure, for example. So one of the things that what I want to advocate for is, when we only look at one disorder and expect that people don't have other conditions simultaneously, we ignore we ignore what this individual is actually experiencing. So the overlap between menopause and Parkinson's disease in terms of voice, for example, is reduced pitch, reduced loudness, inability to get louder, and an inability to control your pitch. Well, if you're only looking for Parkinson's disease, you'll only see that. But some women have Parkinson's disease. And if you are not looking for that, you may ignore it or that condition may be masked. We also know Parkinson's disease co-occurs with depression. So what are the commonalities there? And also a cognitive decline. And so some of these things we've been ignoring. Many women are told in terms of their voice changes, well, that's just it. Like that's 14, 15 years of your life, just suck it up, you know? So we ignore things. So when we think about Parkinson's disease, women are typically diagnosed with Parkinson's disease much later. What does that mean? That means that their symptoms that might have been showing up in voice, as it is an incredible biomarker, might have been ignored. That means the later we catch them, that means the disorders, that they're not going to be able to have the poorer prognosis as well. Anyways, we should also be focusing on treatment efficacy, as I said, and for the interest in time, I'm actually going to go into this last area, which is into pediatrics and adolescent care. Pediatrics and adolescents have been relatively unstudied when it comes to voice changes. We know that men undergo or boys undergo these changes in their voices, puberty, but what are those signaling in terms of other health conditions or wellness conditions has really been ignored completely in this area. And then lastly, I think if we can start looking with a global lens, voice is non-invasive, it's cheap. We can collect it on the fly, we can collect it ambiently. And so it becomes a really great tool for studying populations with low resources as well globally. And because voice, as opposed to speech, is sort of language agnostic, if we just ask someone to say, ah, just from that, ah, you've got a lot of signal that you could use to differentiate between different conditions. During COVID, voice actually became a very interesting tool for assessment of COVID. And cough was also an area that people looked into a lot. So infectious disease is another area that we can go into. So lots of biomarkers, lots of use of voice biomarkers across these different areas. I want to advocate that we could use voice as a vital for health. So just like you go in the doctor's office, they ask you to say, ah, to look in your throat and to see what's going on. Well, say ah also works for us recording voice and for us to analyze that voice as well. Okay. Last but not least, I think we talked this morning about ethical use of voice. Voice is PPI. And so it's really important as we're collecting this data to not forget the fact that we have to make sure that the voice that we're collecting doesn't get into the wrong hands as well, and ethical use and ethical collection of this data. So with that, the takeaways are vocal vitals are a very interesting thing to look at because they're non-invasive, cheap, and all the things I said. But we have to use it with another marker as well. So in terms of integrative health, we have to use voice along with other cues so that we don't overdiagnose certain conditions and sometimes also underdiagnose or miss conditions. And using these aggregate amounts of data, we can also kind of determine what may be going on in terms of across the lifespan for individuals. So thank you for your attention. And I think we can bring together all these areas when we talk again in the question answer.
Right. We're going to try to keep you awake. That was an amazing talk, and it's tough to follow that tough talk. I'm a reductionist, so it's not going to be the complexity that we've been talking. I'm a single organ person. I'm going to talk about the heart. I'm going to talk about predictors, sensors, and AI, and how it all kind of wraps up. And hopefully, I'll manage to. Is there a timer here, or oh, right up there? Okay, so it's going to be turned on. Good. I'll go ahead. These are my disclosures. I don't feel conflicted by any of these in the talk that I'm just about to deliver. Having said that, heart failure, I think all of us recognize it's a complex condition. If you can solve heart failure, you can solve almost any clinical condition within the human body, right? That's because it's a multi-covariate condition. It is a complex condition that is associated with repeated admissions. And because of that, it has the biggest drain on the national exchequer, almost about $70 billion on an annual basis. And that problem is that conventional approaches don't work. And that's why we're thinking about these different predictors, different sensor-based strategies, and different strategies to actually reduce readmissions. The problem, what happens is with every readmission, the patient never really comes back to baseline. They always kind of gradually in a step ladder fashion continue to go decline out there. And how do we kind of prevent that decline? And that's where I think sensors and AI come into play. So if I can leave you with one message today is that the future of care of heart failure obviously is going to be integrative medicine in a big way. But from my perspective, as a reductionist, is going to be an integration of virtual care, which is going to help us deliver integrative care, right? Is going to be sensor strategy that will help us give us biofeedback and allow all the mind-body strategies to actually control those different aspects of care. And then there's going to be large amounts of data, and that's why you need AI there to power this, to be able to bring all of this together to help us risk predict which patients are there and also create individualized treatment strategies. And beyond that, obviously, the biggest issue in modern medicine is that none of this will work unless it is integrated into our workflows. So you need sustainable workflows that then translate into better clinical outcomes. Why do many technologies and strategies never get accepted? Because they don't translate into clinical outcomes. So everything of this complex equation that I've shown you really relates well with integrative medicine, but it all needs to be then shown how it actually translates into better clinical outcome. Just virtual care, I'm just going to show you just the fact that there's a lot of digital divide when you look at virtual care. This is some of the work we did in our group, and we found that despite the disenfranchised individuals not having access to virtual care, which I think becomes an issue for telehealth as well as for the delivery of integrative medicine, that it's really important. But at the same time, I think the future of care virtually is going to be multidisciplinary. We've done a lot of work within the heart failure groups using multidisciplinary care and have shown that this translates into better clinical outcomes. And if you try to position this in the future, even for integrative medicine, we're going to need multiple disciplinary people coming together, working together, and telehealth actually provides that opportunity to be able to do that. Now, I'm a sensor guy. I implant sensors. We implant sensors in the heart. They can measure left atrial pressure. We implant sensors in the chest wall that can measure everything from physical activity, heart rate variability that we talked about, transthoracic impedance, that's the fluid level within the lungs, respiratory rate, tidal volumes. So we essentially digitize the heart with a multitude of sensors out there. I'm not going to belabor them, but there are simple sensors and there are complex sensors that can measure left atrial pressure, can measure cardiac contractility, can measure pulmonary artery pressure, and a slew of them out there that can be used. But all of these are implantable. So your question to me would be, is not everybody's going to get an implantable sensor, right? Nobody wants to get implantable devices. But the fact of the matter is that they're now a cluster, a slew of wearable sensors. Everything that I just told you can be measured now through wearable sensors. These can be sensors that can measure transthoracic impedance. And if a patient is going into heart failure, there are sensors on the rings that can measure your heart rate variability, on your watch that can measure your physical activity and integrate that. There are sensors now from the integrative medicine perspective that can even measure your resilience and help you understand how your body is adapting to stress with daytime stress-related changes in your heart rate. Every organ in the body can be essentially digitized now. I'm just showing you the heart out here. Over and above that, there are ambient sensors that can assess your gait, sensors that can assess your stability. There are sensors on your toilet seats that can measure your weight, record your ECG, assess your microbiome, all in one visit. All right. So you can just imagine how all of this can get integrated with integrative medicine. And I think you can really provide a holistic way of looking after these patients. And obviously, then we have the continuous glucose measure sensors and the others. I'm not talking about voice because I don't understand too much of voice, but I think that is one of the new sensors now that can actually help predict which patients are going to develop heart failure by just the change in their tone, speech, cadence, or pitch, all the other multitude of things that Dr. Patel just showed us. Now, the interesting thing is these implanted sensors have the ability to predict heart failure. So if you look at integrated measure of these different sensor variables, you can actually predict heart failure 30 days before it actually occurs. Okay, you can measure all these different things I talked about, right from heart rate variability, physical activity, everything integrated, and that's some of the work we did with the multi-sense HF study. Problem is a culture change in practice and getting people to understand how it needs to become a part of the workflow, and then obviously imposing different strategies of how care is delivered in the future. So this is a slide I developed in 2009 when I was giving a talk in Venice on cardiac arrhythmias, just to show you that now we are much closer to actually making this a reality. When you think of heart failure, you have stable heart failure, and then the patient then actually develops an acute heart failure situation. What are the transitions out there? There are multiple transitions out there. There are transitions that interdigitate with different disease states, right? Most of these patients have comorbidities such as diabetes, hypertension, COPD, atrial fibrillation, right? They also have triggers such as ischemia, electrolyte abnormalities, arrhythmias that can precipitate the heart failure. The interesting thing is you have sensors for each one of these now. And if we can find a way to interdigitate these sophisticated sensors with all the device data and the simple sensors we talked about with a single thread from a chronic state where you have a baseline neurohormonal situation, whether it's measured through heart rate variability or physical activity, if you can thread the needle using all these, and that's where you need artificial intelligence strategies to really kind of help us analyze, collate, curate, annotate this data so it can be used to provide an individualized prescription to manage these patients in a very individualized way if you can collect all this data together out there. Now, one of the ways that we are delivering care for heart failure patients, and I think, again, really ties in very nicely with integrative medicine, is remote monitoring. Remote monitoring is the way you can actually embrace the life cycle of disease. So you're not looking after the patient only when they're in the hospital, but when they are in their office, when they're in their car, when they're in the outpatient area, in the inpatient arena, wherever they may be traveling across the world. But this is going to require an amalgamation and then a collection of all that data and integration of analytic AI as well as generative AI, so you can then translate some of this work where the patient, him or herself, can actually get involved in their own care with some of these feedback technologies that we're talking about and that you've heard about. Now, I'm not going to talk to you about the data because there's data that we know in our electronic medical records that all of us understand, right? That is our medical covariates, disease covariates, our demographic data, our drugs that we take. But the true determinant of disease are the social, cultural, and environmental data that we can't necessarily measure as yet. And if we do, much of those are in this complex system that we've been talking about today. And how do you kind of integrate that information together? How do you look at proteomics, genomics, which is still under the surface out here? But I think we've started moving in that direction. And I think the important thing that, again, for us to understand is that when we use machine learning strategies, the conventional way of classifying heart failure is very different from the way now machine learning can cluster patients into those that are at highest risk versus those who are at lowest risk. So it really changes the landscape, changes the phenotypes, changes the way we will actually diagnose patients, and at the same time, phenotypic descriptions so that we can individualize our treatment strategies a little bit better. There's a lot of potential for AI in HF, and I'm not going to belabor this because today we're talking primarily of just the prediction part and maybe the diagnosis part. But all the others in terms of new therapeutic targets and drug designs, I'm going to leave that alone. But the ones in red, readmissions and clinical decision, I think all become a part of the equation today. There are many forms of AI that can interdigitate with our patients of heart failure. We're doing a lot of work in many of these arenas. But the simple ECG, a 12-lead simple ECG using machine eyes, you can actually diagnose the ejection fraction, the pulmonary artery systolic pressure, the pulmonary capillary wedge pressure. You can diagnose whether they have mitral regurgitation or aortic stenosis. You can even diagnose the severity of any of these valvular diseases right now. We just got something approved by the FDA as a breakthrough designation by a 12-lead ECG that can actually measure and quantify diastolic dysfunction. So it's really changing. You don't have to do an echocardiogram. It makes it scalable and allows us to actually translate care and bridge that gap between, I would say, global health equity that doesn't exist right now. Generative AI, there are already ChatGPT is being used with these information from the charts to help us diagnose which patients are predisposed for readmissions. And then we have multimodal AI, and I'm doing some work with the MIT folks on that, specifically looking at event-based contrast learning, that is looking at how you use speech to some extent, but largely images, videos, data from the EMRs, and really collate that to predict which patients are at higher risk for readmission, really trying to solve that readmission issue that is a problem. Most heart failure patients all have arrhythmias. And we know now from a patch monitor from the first few hours, you can predict which patient is going to develop atrial fibrillation. We know now from a patch monitor from the first few hours, you can predict which patient is going to develop VT, VF, or sudden cardiac death through machine eyes, really transforming the way of how you risk stratify these patients. And there obviously work from our group and others have shown that you can actually use the watch to drug load these patients at home. Again, experimental, where you can shift care from the inpatient to the outpatient and the outpatient to the home, where you don't have to keep them admitted now, where you can monitor the QT interval changes in the EKG signals using the watch and using some of the machine learning algorithms that we talked about. Heart failure is a problem. Readmissions is a problem. Baseline variables help in predicting immediate readmissions, but as you progress over time, there's a waning predictive ability. And that's because baseline measures are constantly dynamically changing. And that's why you need continuous sensor-based approaches to provide us real-time data so that the predictive models can keep vacillating as the risk prediction for the patients actually goes up. And as you can see out here, most of these over time don't work as well. I'm very close to the end, but I think when you look at medicine as a whole, I look at it as a pyramid structure, where most of the care is at the wellness at the bottom, which is called mainstream care. Midstream is chronic disease, all the chronic diseases where we spend $3 or $4, and the top is complex surgical interventions and complicated care. Integrative medicine can solve the wellness issue. If it solves a wellness issue, you're going to have a reduced chronic disease issue. If you have a reduced chronic disease issue, you're going to have a much lower need for complicated interventions that actually are depleting our system out here. So our focus really needs to be at the mainstream and at the wellness level and really maintain health, as was told at this morning's talk. How do you kind of define health first and then maintain that? So the future of care in heart failure, if I can say something, is going to be predicting and preventing heart failure. Obviously, I think a combination of sensors and AI is going to be important. I think making this scalable, this digital equity, will potentially help in creating health equity across the globe. And then I think we need to construct these high-touch digital pathways that will redefine the value proposition, shift care from episodic transactional care to something that's more continuous, create these disease-specific multidisciplinary virtual models, which I think are the future for across medicine as a whole, creating previvor platforms before patients actually have disease rather than survivor platforms later on, and then obviously engage the patients in managing their own disease, as we call the MYOD concept. At the same time, I think it's really important that we don't make care a digitally exclusive experience. I think it's really important that too much connectivity can disconnect us, and that this so-called personalized care might become impersonal. So it's important for us to really keep the human bond in while we start engaging with the digital touch. Thank you again for your kind attention.
I'm really honored to be here. I think both Rupal and Jagmeet have set a beautiful stage for us to get you to something that's actually therapeutic, moves away from detection. And I'll start a little bit with my story before I put a slide up. I have been a lifelong user of antibiotics, nasal sprays, corticosteroids, because I've had breathing problems through my nose my whole life. The year before the pandemic, I was shuttled off to see one of the top sinus surgeons in the nation, Dr. Peter Huang, who heads up the Stanford Sinus Center, and he refused to operate on me. Instead, he gave me the tools to manage my congestion. And what you're about to see is a story of how my life has changed because of acoustic resonance and AI. So, there is all of the work that's been done by all of the folks in voice and art. There's a great deal of promise that I see over the next 10 years. I will tell you that we are leading the charge to bring therapeutics. We're moving away from detection to therapeutics and combining this to give you things that you can actually use to change your state of being. So I'll start with ancient wisdom because we're here with the integrative medicine community. Human beings have been around longer than AI. So there's a great yoga sutra, and it basically talks about how breath is life. So I start with that because if you look at mind, health, and your overall sense of being, there is one thing that pervades all of it, and it's breath. We breathe 26,500 times a day. It's the most important and the most critical thing you can do to maintain your life in this human frame. So fMRI and AI have caught up. This is a paper from last month. There's a clear view now of how the nose, which by the way has been treated as an organ. There was not even rhinology 30 years ago. It was ENT with the N missing, otolaryngology, as Peter says. Now we have rhinology. And I would submit to you that we've now established the firm connection between cerebrospinal fluid, hypothalamic centers, the midbrain, the forebrain, the voice, and breath. It has always existed, we're just discovering it. So, what does this help us do? Rupal so beautifully talked about voice and the plethora of disorders that it can signal well before it happens. And Jagmeet so articulately explained how he can see things 30 days before you would have a heart attack. I submit to you that if you listen to your voice and if you breathe right, you can get ahead of all of this stuff as he put on his last slide. You will be in the wellness zone. So what we did, I'm going to show you what I showed a patient before we had our first device. And this goes back to an earlier talk this morning. Make sure that your patients want what you're building. So here you go.
Allergies? Stuffy nose? Introducing Sonu, a new drug-free, personalized, clinically proven system for the relief of moderate to severe nasal congestion. Sonu uses gentle micro vibrations to soothe your nasal passages and sinuses. Sonu dramatically reduced nasal congestion in 80% of patients. 3 simple steps to better breathing. Take 3D selfies with our AI-enabled app, which uses machine learning to determine your resonant frequencies. Put on the Sonu band. Turn on the resonance. Go about your day. Breathe effortlessly within minutes. You only need to use Sonu twice a day. Sonu by SoundHealth. Our science is sound.
So a lot of this credit for this device goes to my 2 co-founders who are incredible docs. One of them is an MIT engineer who became a doc. So there's a lot of East Coast DNA in this device. But how does it work? Today you go get a CT scan. In fact, most people who have rhinitis don't even get a CT scan. I was talking to Dr. Saha, who works with Kari Naidu at the Harvard School of Public Health and Environmental Public Health. And she said, most of my allergy patients suffer for years without understanding what's going on with them. So the basis of any therapy has to have believability. Why do I say that? Today, I believe Flonase is going to work. Why? Because it's 20 years of double-blind, sham-controlled trials that have been done, but there's really nothing personalized about Flonase, not even the dosage. Now, one of the first things we decided to do, actually what Peter did for me, was he took my CTs and he actually asked me to meet him for coffee after I saw him, and he refused to operate on me. And he calculated all of the fundamental resonances of all the bony parts of my skull. Then he gave me a bunch of toothbrushes and a bunch of buzzers from Home Depot that he strapped onto my head. And he said, go and hum for 5 minutes and let these sounds get into your skull for the next 2 weeks and tell me how you feel. And that was a moment of great revelation for me, because I figured out that I didn't need to use Flonase to feel my nasal passages opening up. Then the pandemic hit, and we're like, well, how do we take this technology and make it broadly available to everybody? And that's where the technology comes in. I'm an electrical engineer and computer scientist by training. So we actually published this week the landmark paper on being able to use smartphone photographs to get within 5% of a CT scan of your entire skeletal structure on your head. So your sinuses, your ostia, your sinonasal cavity, we know all of the bony landmarks, and add voice to it, we know we know the opacity in your sinus cavities. And if you're a singer, as we just had some of the top Broadway coaches and musicians use our devices and our technology, you can actually tell where your formants are going to be, because you know the sonorance of your nasal cavity and how it is occluded or not occluded based on our technology. Now, we took all this cool detection stuff, and then we come to what you're going to, I'm really looking forward to Todd and team this evening, because music is the key. In fact, we spent a year with the Stanford neurologists and the musicians to figure out how to get not toothbrush tracks, but how do you get a proper, beautiful track that you can play that encapsulates all of the statistically significant frequencies between your ethmoidal cells and your maxillaries and your frontals, to make sure that you can actually not tolerate, but enjoy the treatment. So if you're around afterwards, go try it, and you can probably see how you feel before and after. Anyway, what are we actually doing? We didn't know this until a year ago, because everybody said, how the heck does this thing work? So it turns out that it's an autonomic downregulation of the actual nasal nervous system. So there's something called the sphenopalatine ganglion that sits behind your eyes that actually controls all of the functions of the nasal cavity. And I think Peter will do a better job of doing this than me, but he says the highest amount of intervention is when I put lidocaine into the sphenopalatine ganglion, and I kill all of the pain associated with a migraine or with chronic rhinitis, where you can never stop your nose from flowing. And the most benign form is vibratory excitation, is what we're doing with music through the bone. We're conducting music through the bone into your skull. So we're resonating the sinus cavity. So we're moving the air in and out of the sinus cavities. So what then happens is, if you have mucus, and as it's funny, I went to a VC meeting a year and a half ago, and the guy tried it on, and he goes, I didn't take my Allegra this morning, and he brought out a big ball of snot. Because what we essentially are doing is changing the air in the airway, and we are actually decoupling the viscoelasticity from the mucus and making it drain. So we have mechanical aerodynamic effects along with autonomic downregulation that is changing the entire state of the nasal cavity and making you breathe right. And that's why when we went to the FDA, they said, we don't know of any of this stuff. And by the way, this is a rhinological scoping examination of a patient, and you can start to see the effect. This is the right-hand side turbinate and the septum, and you can start to see the vasoconstriction change the nasal cavity's volume as the vibration sets in. Then we went to the FDA, and the FDA said, we don't know what this is all about. We have nothing like it. And we went through a 2-year regulatory, I call it the biggest ride in my life. I come from the tech world where, products take 18 months. This is not 2 years, it's almost 3 years. So we did it was de novo, no predicate. So we established the first ever vibroacoustic therapeutic device that you can buy today. That's the amount of work that went into it, which is equivalent to the indication that Flonase got when it was released in 2010. So if you're an internal medicine doc and the first line treatment for this was Flonase, now you have an alternative in your toolbox. And we've been very fortunate because we had rhinologists from all over the country, Ben Blyer at Harvard, a bunch of folks at Columbia. Because of Peter and the reputation that he had with the rhinology community, He didn't even believe this data until we did the trial, multi-center, multi-season, ethnographically balanced, because people with different ethnic backgrounds have different skeletal dimensions, and our machine learning had to make sure that it's translatable across all of these different classes of population. So these are the results. You can go get the papers. It's been published in IFAR, published in the IEEE. We now have on the left-hand side are the two, by the way, these scales are pharma scales. They're used to basically grade corticosteroids. So the total nasal symptom score has 4 buckets. It has rhinorrhea, nasal itching, sneezing. And basically we were statistically significant by patient number 11 out of a total of 75 that we recruited for this trial. We have now over 10 studies, and this was our 5th study for the FDA. It was not a passive sham study. So if you're counting, this was around the time that the FDA found that phenylephrine didn't work. So they basically made us do an active sham. So we had to take every single sham patient and give them a frequency outside their therapeutic range. So it was an active sham control trial, right? And you can tell that, with that, the data is extremely, extremely promising here. One other thing, which leads back to the neuroanatomical piece of this, is that people got better using it. I've not taken a single spray in 4 years. No sprays, no antibiotics. I can get on a flight, get off, no problem. I used to pop pills when I went to Hong Kong because I knew that when I'd land, when I go to a meeting, I wouldn't be able to handle it. So you can actually see sham stays the same while the actual effect size actually increased for week 2. How does this compare to Flonase? 2 separate studies, almost equally powered, almost a decade and a half apart. Actually equivalent effect size and two equivalent sham size. So you now have the first therapeutic that's AI enabled, that's available today, OTC, to be able to give you an alternative to a nasal spray. Well, let me get to my last part of my presentation, which is 50% of us breathe through our mouth. I mean, there's so much evidence on this, even before Nestor wrote Breathe. And it's a huge problem because we were meant to be breathing through our nose. And if you ask why, the 1993 Nobel Prize was given to a bunch of scientists that determined that the most important function of the paranasal sinuses is the production of nitric oxide. And nitric oxide is the key ingredient that maintains proper immunity in your entire upper respiratory complex. So by definition, if you're breathing through your mouth, you are at risk for a whole host of diseases, which is why all ancient practices, all integrative practices, always talk about breathing through your nose. Number 1. Number 2, kids are mouth breathers. 30% of them, if you go to an orthodontist, they will tell you that probably 30 to 40% of their children are mouth breathers. That's already, you can catch it really early, right? And then of course, if you're a mouth breather, sleep disordered breathing, apnea, all of the appropriate sleep apnea pieces come to bear and start to stalk your entire health. So we have to catalyze nasal breathing. Our mission as a company is to make people breathe right, because if you breathe right, I think at least we will solve the bottom part of the health pyramid piece, right? So what do we do today? Well, there's blood sugar monitors. We all wear them. I wear them. Why? Because I'm not diabetic, but I want to hack my body to make sure that I never get there, right? So what is the one thing that we all need to do? We have to catalyze awareness. And if we can catalyze nasal breathing awareness by a simple app, in fact, I was talking to Rupal earlier today. So much pioneering work has been done on voice. We took a small piece of that she put up there, and you can download our app for free. We have a complete nasalence and patency check we can do in a single button with 4 words, because we look at the signal processing associated with saying nasal phonemes versus oral phonemes, and we can calculate the patency of your nasal tract equivalent to what you would go to an audiologist's office or equivalent to a PNF meter. So we know the patency of your nasal tract by just 4 words. On top of that, we are personalizing everything to your anatomy. I mean, the one thing that I really took away from all of the stuff that I learned over the last 2 days is the integrative medicine aspect of medicine really actually delves into the person. It's the person that you're looking at as a whole, not a person as a part of a sea of statistics, right? So the personalization of all of this is so important. And then we have to make it fun and we have to game it. So I have kids now that are using our app that want to compete as to who can breathe with their nasal breathing better between a cohort of kids. We're doing a pediatric trial for the FDA because we're going to get a pediatric indication, touchwood, by the spring of next year, right? And then finally, you have to sustain and reinforce. I mean, I believe all the cool stuff in the yoga, but I love to look at my graphs. I love to look at data. Data makes me the faithful. So data and data science is crucially important to making sure that your doctors, your practitioners, your therapists have a way to be able to shepherd your longitudinal, sustainable health. And then finally, I was talking to Darshan and he sent me an interesting question. He says, where's the future? So we found, then we did our first 2 studies, that 40% of people went to sleep wearing our band. And it was so curious. Why did, of course, we're opening the airway, we're getting more oxygen. Yeah, but it just doesn't comport. Why are people falling asleep? So we went to Cleet Kushida. Cleet was one of the pioneers of sleep medicine in this country. He heads up the Stanford Sleep Center. And Cleet had a brilliant idea along with my co-founder, Brian Lynn. He said, I think it's something that you're doing with the music to stimulate parts of the brain to go to a state of rest. And so we went back and looked at all the literature and said, well, what is the closest that music has been used to put people to sleep? And there's been lots of research done on binaural stimulation. But just like humming, binaural stimulation had one big drawback. People don't like to hear binaural beats in Handel's water music. I don't, right? Imagine seeing this binaural mixed 2 or 3 hertz, embedded in Beethoven or Handel. No, that's not cool. It really is actually dissonant. So Brian came up with an amazing idea. He used spatial musical transformation. So when you have binaurality, you have 2 frequencies that are separated in integer frequency, 2 sinusoids separated in integer frequency, going through the air, through your ears and stimulating your brain to the actual difference in frequency. What we've done with our band, and we ran a pilot study, was we spatially separated them. So there's no dissonance and we are delivering them through bone. So there's no relative air-based sonic delay. And we were blown away. We just presented the results at the European Sleep Research Conference. We took 23 people that came in for psychiatric insomnia DSM-5 evaluation, and we dropped half of them below the threshold for insomnia after 4 weeks of use, 45 minutes a night. And so we're now working with the FDA to work on a trial, a pivotal RCT for this, to really change. And again, why did it work? We use their skull resonances. We use the resonance of your cranium. So when we deliver actual sound into the cranial cavity, we're able to get you the right hippocampal stimulation to synchronize you vibroacoustically, not with air, through bone. So you ask me where this is going to go. Well, here's my 10 cents for the future. I think psychiatry and psychology in the internal medicine space have postulated for a long time that most of us in our waking state are externally focused. Our entire energy is actually dealing with threads and people and tasks that are removing our awareness from ourselves, our internal selves, which means that we are not synchronized with our breathing. We don't have any awareness. So as we delve into this, and we say that, I call it the identity function. This is not me, a bunch of psychologists came up with this. If you can start to go more into your own self, your identity, devoid of all of the distractions around you, and get connected to that identity with your breath, then you have an amazing ability to change the default mode network in your neurology. What do I mean by that? Today, you have your brain connected And it's connected because there's multiple pieces of it that's electric of your brain that are electrically processing the world around you. If I can start to isolate them, like, and become a, the right-hand side is a monk, Buddhist monk meditating, where the notion of language, identity, and externality is moved out. And which is why so many studies have been done in the last 2 years about yogic sleeping and yogic nidra. You are actually able to use meditation to go to sleep with sound. And if that happens, I postulate that we're on a new brink of using music, meditation, very personalized to you, not generic, to really change your waking and your breathing. Thank you so much.
Thank you. I'm going to invite our three distinguished individuals to come to the front here. We're going to be a panel. What amazing set of talks, and just and I'll invite people to come forward with questions or reflections. But one of the things, just to get the discussion starting, as we think about some of the all of you talked a little bit or alluded a little bit to about the digital and cultural divide that needs to be addressed in these sort of, as we think about technology. So for example, I'm curious, and with each of you just thinking about sort of the lens by which you approach this panel, thinking about language, for example, like how do you think about in different languages, what does intonation mean? And in terms of a predictability of like, I imagine most of the work is English centered. And so then how do we think about in other languages that use nasal sounds or use soft palatal sounds or other types of things? I'm thinking as we think about the heart, for example, where do you see sort of different, we have obviously our group here does a lot of work in the sort of Tai Chi and heart failure as an example, but how do we think about different cultural traditions that have tried to sort of provide some sort of, and how does that fit into the schema of, and then finally, as we think about the breath, when you think about, are we risking, and I'm going to sort of pose this question, that how do you avoid some of the biases that may, that's already present in some of the literature around, say, race, facial structure, that may be inherent, and how you are going to address that as you think about developing something that is equitable. So those are 3 questions for each of you, but anyways, and you can certainly answer somebody else's question too.
Yeah, I think that's.
Yeah, I think it's on. It's good. Yeah.
All right. So in terms of how does language impact what we hear? So certainly every language is going to have its own group of sounds, but you could load the sentences with, nasals like Gopi was talking about, and you can have different kinds of sounds that you're actually using for the analysis. I think the one really nice thing about voice, though, is that it is kind of, when you ask someone to say it's kind of the same thing in every culture, right? And so what we're looking at there is really the phonatory signal. So what voice is you're looking at respiration combined with what happens when you valve respiration at the vocal fold level, right? And so there you're capturing both respiration and phonation together, and you're kind of analyzing those. When you add the layer of speech about articulation, regardless of which language you're speaking, you can still look at the coordination between those systems and the movements of the lips or the movements of the tongue. So I think every language will have a slightly different set of stimuli, but we can analyze the same sort of correlates in each of those languages. And I think that's what the power of speech is that actually for many people who don't read, for example, there's so many tasks that we do typically where we're asking someone to read something or we're asking someone to say something, but like if you can be dealing with someone in Africa or India or people where there are places where there's low literacy, and you can use speech and analyze that as opposed to having a cognitive task where you have to have language.
I just to stick to speech for a second, I think it's the way of really democratizing healthcare. Really kind of, you always wait for disruptive tools from the lower socioeconomic countries to come forth because they need to, cater to their healthcare. But I think speech is going to be certainly at the forefront out there. And I think it'll be disease specific. And then beyond that, I think it has so many roles, as you so nicely alluded to. It has a role in heart failure too, but I'm going to stick to my part of the question, which is a complex question. You know, I think the issue with heart failure, we know that, you know, yoga, meditation, Tai Chi have all had beneficial effects on the heart. We know they reduce the incidence of arrhythmias, talking as an electrophysiologist. We know they also reduce the incidence of vasovagal syncope. I had the honor of co-authoring a paper on that with some of the folks from All India Institute of Medical Sciences who have an integrative health center out there purely for yoga. I think the question you're asking in between the lines, if I'm correct, is how do you get this integrated into clinical care as a part? And I think that's what you need for that is measurables, is data that the existing clinical world can relate to. Because that is going to, I mean, you might have an overall beneficial effect, but if you don't have a clear intermediate surrogate variable that correlates to it, the palatability of new strategies to the average allopathic clinician, and I really mean average because they think in reductionist terms like I do, I think really you need to transcend that by having these measurables. When you use things like heart rate variability, you know, I did a fair amount of research on heart rate variability in my past life when I was doing my doctorate. This is many years ago. It's found its role as a diagnostic tool to somewhat predict worse outcomes, but it hasn't found a role as a therapeutic tool. How do you kind of bridge that gap out there? And I think that's where these, integrative medicine with Tai Chi and meditation, yoga can create the intermediate variables that people can see do correlate with this. A plus B is equal to C because of these things. I think that is going to create a greater acceptance of those strategies. And then obviously it's behavioral change is always challenging. You know, it's easier to take a pill than to actually have that behavioral change. I think we are in a unique era where variables now, through their nudges and through constantly providing data, are actually able to influence behavior. I just recently started wearing the Oura Ring, and I was my sleep patterns were dismal. But over the last month and a half, they've changed tremendously because of continuous feedback. Even my resilience, which is measured through the ring, was terrible, and now it's much better. So I think we have to create this culture where people are engaged in their own health through technology that provides them constant data that they can work off and see the measurable change that they have with that.
So
Can you hear me?
I think it's off.
There you go. Okay. I want to emphasize a few things. One is sound is the basis of language. We think in terms of sound. So I'll go back to my early I was fortunate to learn Sanskrit when I was a kid. And it's interesting because if you look at the phoneme set, it has all of the Asian language phoneme sets in it, including r, l, all of it. So to Rupal's point, we have enough data today, spoken data, where we can actually apply phoneme boundaries. In fact, if you look at what we're doing today with our speech detection, we're applying phoneme boundaries, not linguistic word boundaries, because at the end, you're thinking in terms of sound. And the other thing I want to emphasize is that you asked about racial equity, and the FDA had the same question. It's interesting. I almost hear the FDA echo in you. But you know, it's really interesting to see that at the end, we're all bone, right? I mean, if I look at your orbital landmarks or your alar edges or your mouth or your tragus to nasospinal distances, to me, you're a piece of bone, right? So from an AI point of view, that's the type of data that we need to really structure things to give you the right feedback, right? I'm a big fan of subjective when it comes to my individual data, but when I try to generalize across a population, I lose depth, right? So mathematically, I want to get to as close of the ground truth as possible. And so when we talk about equity, the first thing we need to make accessible is all of this has to be on this phone. The cameras, we're working with Samsung right now because the depth cameras have been removed from Android phones, believe it or not. Now they're going to make a comeback, but because of the AI that we have today, we're using depth cameras, thanks to Apple, and big shout out to the Apple guys, because they kept the depth camera on the phone. So you actually have a cellophane map of light that somebody's stringing across your face. And if you're a surgeon, I mean, I've scrubbed into 20 operations with Peter. So we register a person on the OR table and we take a picture, we take a scan of him. So we can get to, if you're a surgeon, you understand that anatomical landmarks are critical to guide things into small spaces. So the notion of getting that level of precision is now possible because we have these types of things floating around with people in countries like in Vietnam, where I ran a center for many years. They all had iPhones. So I think, to your point, we have a large set of data, and I think it's really important to start working on therapeutics. I'm going to come at this from a very biased point of view because I live in a world in a sea of data. I want to do something with it. So when I hear all of your ideas, I'm so thrilled because to be able to give somebody a task saying, here's what I see you're going to do as a doctor. And if you want to not have a heart attack by the time you're 60, do these 3 things, that's awesome, right? So I think that's important.
Yeah. Okay, I'm going to ask one question to each of you. The same question to each of you, and sort of because all of you have worked with industry, have had industry partners, or from industry you've had sort of a health partner, a health professional partner. What is one, just from the work you've done what is one cautionary tale that you've learned that you sort of, as you think, because all of you have had tremendous experience in this arena, is there a cautionary tale that you think that this is something important to recognize as we move forward in this work?
Yeah. I'll go first. I think working in an academic environment, you're always made to believe that working with the industry is not a good thing. But there was, I don't know if you know Bob Rubin, who was at MIT, who was a mentor when I was doing my master's there. He said, Jag, how interesting you are is measured by how many people are interested in you. And I took that to heart and I said, you know what, I enjoy working with the industry because it really keeps me at the cutting edge. It allows me to think ahead of many of my peers who are immersed in clinical work, but not necessarily always thinking of what's ahead. It allows you to laterally grow beyond your area of expertise, but allows you to kind of think how that area of expertise can be laterally spread in many different directions. So I would strongly encourage academics to have that relationship because I think the future of care is eventually tied to the academia and industry complex working together, especially as you look at all the algorithms that are being developed across the EMR systems. You need to be working. I mean, for example, Mayo Clinic has a platform system out there where they have multiple startups, almost 200, working with their entire database across the board, and each one cross-working with each other, which is now an alternative source of revenue for the institution while they're innovating. So I don't personally have any bad experience besides the fact, I go through the Office of Industry Interactions at MGH and they vet every agreement. So I know I'm covered and there are no issues out there. I've never had any personal patent issues because I haven't engaged in that end of things. But it's been overall a great experience.
Yeah, I would definitely echo that. I would say in terms of cautionary tales you asked for, right? So I think that you don't want to have perfect be the enemy of good enough. And also the other big lesson I learned was that sometimes as scientists trying to bring something to market, you are so focused on accuracy all day long. But preference is what we learned in my former company in Vocal ID. This is when we were creating synthetic voices. We were so focused on making an accurate voice for that person, something that could be believable that they could produce that voice. But what mattered in the end was whether it was a preferred voice, something that they liked to use. So we could have worked all day long on getting that voice to sound exactly like it should have sounded for that person's anatomy and so on and so forth. What mattered is, did they like it? Right. So sometimes we have to put and this is why, you know, Polaroid and what's the other company? Polaroid and no, not Xerox, the other photo company, Kodak. The war there was, you know, accuracy failed, but preference won of the day. So really thinking about not just bringing to market something which is fully accurate. Obviously, it has to be accurate if it's medicine, right? But you have to think about, is the person going to use it? Is that UI good enough for someone to use every day? And that's where preference comes into the mix as well.
I'll answer in a slightly different way. I think that, you know, as medical professionals, I'm on the other side coming from industry. I'm very fortunate to be part of the Stanford community. And the reason is the valley is it's like an effervescent boiling pit of all these ideas that keep kind of getting circled around, right? There's one thing that I learned though, which is I think to fail fast and to fail quickly and not be afraid of trying stuff is critical, right? So cautionary tale. We could have gone and we could have done a startup to look at, you know, whether you're going to have a stroke or a seizure. But the fact that, you know, Peter and Brian, they've done companies before, they were like, let's focus on something that we can actually, we're not doing, this is not high tech compared to all the stuff that Rupal does. This is low tech, right? And I'm talking about relative in terms of data sets. We're looking at congestion. It's a very important problem. So bounding the problem to something that you can look at whether it's going to succeed or fail fast or succeed is really important. So my view is if you can, you know, put a bounding box around the jelly of clinical outcomes that you want that are going to make a difference in somebody's life, do it fast, right? And don't wait, as many academic, you know, studies suggest. And don't take half steps, take a full step.
Well, I want to first thank our esteemed panel for just what an amazing set of dialogues. And again, just lots for us to think about. I know we'll have time in the break for people to interact, but I also know that Jag has to head back to the hospital. So I want to be sort of also so, but thank you again very much again for all of you and for just really amazing contribution that you've provided, and lots to think about and again, lots to engage with as well. So again, thank you.
Oh, it was amazing. What a fantastic session. Really, really amazing. Yeah.
Okay. Thanks. Yeah. Thanks so much. We're gonna take just a 10-minute break as it gets set up. So we'll start right at 3:30. 8-minute break. 8-minute break. We're gonna start at 3:30.